Imagine paying, I don't know, over $1,000 to enhance the absolute most sensitive nerve endings in your body.
Yeah, and then waking up 3 weeks later completely numb.
Right, just a total terrifying void, no sensation, no arousal. Welcome to today's deep dive. We are unpacking a huge paradox today.
We really are.
We're looking at the O shot, right? The orgasm shot. It's a treatment that promises to rejuvenate vaginal tissue, boost your natural lubrication, treat incontinence, and massively heighten sexual arousal. And it does all this using the regenerative power of your own blood.
And to really understand this, we've pulled a massive stack of sources for you. We've got clinical guidelines from women's health clinics, scientific reviews that dive into the cellular biology of blood plasma, plus patient testimonials from provider review sites, and some pretty sobering medical leaflets.
Yeah, those leaflets are intense. They're all about the mechanical risks of injecting needles into the body because the marketing brochures, they focus entirely on the benefits, reversal of tissue thinning, better orgasms, basically a total reset of the biological clock down there.
Right. The benefits sound incredible. But that's not exactly our main focus today.
No, our mission for you today is to investigate a highly specific, honestly, much darker question that's buried in all these sources. Can injecting a needle into the most densely packed cluster of nerves in the female anatomy actually cause nerve damage, numbness, or a total loss of sensation?
And to answer that, we have to look way past the marketing. We need to understand the biological reality of what clinicians actually call an artificial scab.
Which is such a wild concept.
It really is. Plus, we'll look at the mechanical risks of the needle itself and why feeling less sensation might, bizarrely enough, be a sign that the treatment is working exactly as intended.
Okay, let's unpack this. Because we have to establish what this procedure actually does first. We really can't understand the risks without understanding the mechanics.
Exactly.
So the O-shot begins with a pretty standard blood draw from your arm. That vial of blood goes into a specialized centrifuge, which spins it at this highly calibrated speed.
Right, and the gravity basically separates the red and white blood cells from the plasma.
Yeah, and what the clinician is trying to isolate is PRP, which is platelet-rich plasma. But why platelets, specifically?
Well, so platelets are usually just thought of as the cells that stop you from bleeding to death when you get a paper cut, right? Like they clump together to form a clot.
Right, the scab makers.
Exactly. But their secondary function is what the O-shot really relies on. Inside those platelets are these tiny little storage sacs called alpha granules.
Okay.
And when platelets activate at the site of an injury, they crack open these granules and just release this massive payload of growth factors into the surrounding tissue.
And the sources specifically highlight vascular endothelial growth factor, or VEGF, and platelet-derived growth factor, PDGF. So we aren't just putting blood back into the body willy-nilly?
No, not at all. We are concentrating the very specific chemical signals that tell the body to build brand new tissue. Think of those growth factors like chemical flares going off in the dark.
I like that analogy.
Thanks. So when VEGF is released into the vaginal wall or the clitoris, it binds to receptors on the outside of these existing microscopic blood vessels. And this signal literally commands those vessel walls to break open and sprout brand new tubes.
Wow.
Yeah, it's a process called angiogenesis. More tubes mean a permanent increase in blood flow, which translates to, better engorgement and natural lubrication.
And crucially for our investigation today, these growth factors are also meant to support nerve regeneration. They literally signal local stem cells to repair and grow new sensory nerve endings.
Right. So once the provider has this concentrated liquid gold, they apply a really strong topical numbing cream.
Which you definitely need.
Oh, absolutely. And then they inject this fluid directly into the anterior vaginal wall, the G-spot area, and then directly into the clitoris itself. The biological goal here is profound. You're delivering the ultimate building materials straight to the site that needs rejuvenation.
But, and this is where I push back a little, if we're pumping a fluid designed to heal delicate tissue into the body, we really can't ignore how we're delivering it.
Right. The delivery method matters.
It sounds like trying to carefully aerate your lawn, but risking driving the spike straight through the main underground water pipe. I mean, we are talking about trying to heal microscopic hypersensitive nerves by driving a sharp metal wedge straight into the densest nerve cluster in the female body.
It is definitely a paradox.
You are deliberately causing trauma to deliver a cure.
Yeah, and the delivery mechanism fundamentally changes the environment before the fluid even gets a single chance to work. We really have to separate the biological magic of the PRP from the literal physical reality of the needle.
Which brings us to the patient information leaflet in our stack. This one is from the Golden Jubilee University National Hospital. Now, this document is about peripheral nerve blocks generally, not the O-shot specifically.
But the anatomy of a needle injury is completely universal. When a metal needle enters a space that's packed with nerves, the physical risks are just immediate.
Right, because a nerve isn't just a single wire, is it?
No, it's a bundle of fibers, and it's wrapped in this protective outer sheath called myelin. And if the bevel of the needle even just lightly grazes that myelin sheath, it disrupts the nerve's ability to transmit signals cleanly.
The leaflet notes this can instantly trigger neuralgia,
Exactly.
which is that sharp electric shock type pain that shoots through the area. The nerve is basically short-circuiting because its insulation has been scraped off.
Yeah, or it can manifest as hypersensitivity,
Yeah.
where just a really light touch feels overwhelmingly painful. Or conversely, the structural damage can completely block the signal, and that causes sudden numbness.
Just deadened completely.
Right. But direct contact between the needle and the nerve is actually just the first hazard. The secondary risk is often a lot more insidious.
Because the area down there isn't just packed with nerves, it's heavily vascularized, meaning it is just full of tiny blood vessels. So if the needle misses the nerve but nicks a blood vessel on the way in, you get bleeding under the skin.
And, a little bruising is normal with any injection, but if the blood pools, it forms a hematoma.
And this is where the specific anatomy of the clitoris and the vaginal wall becomes a huge liability. These are really tight, enclosed anatomical spaces.
Yeah, so if the hematoma forms, that blood literally has nowhere to go. It begins to take up space, which raises the pressure inside that tissue. Medically, we call this a microcompartment syndrome.
So that expanding pocket of blood is now physically crushing everything around it, including the nerves.
Exactly. And nerves are incredibly greedy for oxygen. They require a constant, massive blood supply from microscopic capillaries just to stay alive.
Wow.
So when a hematoma presses against a nerve bundle, it squeezes those feeding capillaries completely shut. The nerve is suddenly cut off from its oxygen supply. This state of oxygen starvation is called ischemia.
So the nerve isn't necessarily damaged by the sharp tip of the needle itself. It's literally suffocating under the pressure of the internal bleeding.
Yes. And that explains why our sources put a massive red warning label on patients who are taking blood thinners or who are dealing with clotting disorders.
Right, because if you can't stop that internal bleeding quickly, the hematoma just grows and the nerve starvation gets even worse.
The medical history assessment you do prior to this procedure isn't just like annoying paperwork. It is literally the primary defense against ischemic nerve damage.
Okay, but we have to look at the statistical reality of this for a second. If a patient gets the O shot and a hematoma suffocates a nerve or the needle grazes that myelin sheath, are they permanently numb, like forever?
Well, if we extrapolate from the broader medical data on nerve block injections, permanent structural damage is highly uncommon. The estimates place permanent nerve damage at somewhere between 1 in 2,000 to 1 in 5,000 cases.
Okay, so it's a very rare outcome, but it is absolutely a non-zero risk.
It is non-zero, yes. But the human body is incredibly resilient. The data shows that between 92 and 97% of people who experience these mechanically induced sensory changes recover completely within 4 to 6 weeks.
Oh, that's fast.
Yeah, the myelin sheath actually repairs itself, the hematoma gets reabsorbed by the body, the internal pressure drops, and oxygen returns to the nerve. By 3 months, 99% of patients have fully recovered their sensation.
Okay, but wait. If permanent structural damage is that rare, we have a major discrepancy to resolve here.
How so?
Because our sources contain very real, very frightening reports from women who undergo the O shot and experience a massive, terrifying drop in sensation. And it's not a 1 in 5,000 anomaly in the forums.
Right. This is actually the pivot point of our deep dive.
Yeah.
We have to shift from the mechanical damage of the needle itself to the actual biological mechanism of the PRP fluid.
Let's look at Priscilla. We have her documented review from a provider website in our stack. She paid over $1,600 for the O shot the week before Christmas, looking for enhanced sensation. And 3 weeks after the procedure, she writes this review in an absolute panic. She states she's almost completely numb around her clitoris. She has zero sexual desire, and she's entirely unable to achieve an orgasm. Whereas before the shot, she had no issues using a vibrator.
The psychological weight of that outcome, it cannot be overstated. Experiencing iatrogenic, which basically means doctor-caused loss of sexual function, is terrifying. You pay a premium to upgrade your body, and you wake up feeling like you've been permanently disconnected.
The panic is entirely justified. But the clinical team's response to Priscilla's review completely reframes what is actually happening under her skin.
Right, because they point out a fundamental misunderstanding that most patients have. People think of the O shot like a dermal filler.
Right, like injecting hyaluronic acid into your lips, where
Oh,
the gel just sits there inertly and plumps up the tissue instantly.
exactly, but PRP is not an inert gel. It's an active, aggressive cellular therapy. When you inject concentrated platelets into the tissue and they crack open those alpha granules, they don't just gently coax the tissue to grow.
What do they do?
They deliberately trigger a localized, really intense inflammatory cascade.
Wait, inflammation. I thought inflammation was the body's warning sign that something is wrong. I mean, we usually take medication to stop inflammation.
In chronic conditions, yeah, inflammation is damaging. But in acute healing, inflammation is basically the necessary demolition phase.
The demolition phase. I see.
Yeah. When the PRP triggers this response, white blood cells called macrophages rush in to just clear out old, dead cellular debris. Then fibroblasts arrive and start furiously laying down new collagen scaffolding.
Okay.
The clinical texts actually use a highly specific term for this phase. They call it an artificial scab.
An internal scab. Okay, so if we think about a scab on like a scraped knee, it's thick, it's firm, and it's notoriously dull to the touch. It definitely doesn't have the delicate sensory capabilities of normal skin.
Exactly. Because the microscopic architecture at that stage is completely chaotic. The fluid buildup from the inflammation is swelling the tissue, which is gently compressing the thousands of micronerves in the area.
Makes sense.
Plus, the fibroblasts are laying down a rigid collagen matrix that hasn't softened up yet. So while that internal scab is present, it creates a literal physical barrier that decreases sensation.
So what does this all mean for Priscilla? That maps perfectly onto her timeline. She wrote her panic review right at the 3-week mark. She thought the numbness was the final result of a botched procedure.
But 3 weeks is exactly when the biological construction site is at its most chaotic. The clinical response to Priscilla explained that it takes a full 2 to 3 months for the new, healthy, highly vascularized tissue to fully replace that artificial scab.
Oh, wow.
Yeah, the peak results, the enhanced nerve sensitivity and the new blood vessels, they usually don't even manifest until 8 to 12 weeks post-procedure.
So Priscilla's temporary numbness wasn't a sign of permanent nerve suffocation. It was biological proof that the PRP was actively remodeling her tissue. The numbness was the scaffolding.
Yes, but it's deeply counterintuitive for the patient. You expect an immediate linear improvement. But cellular biology requires tearing down the old structure before the new wiring is fully operational.
Yeah, and there are multiple reports in the sources from women who experienced this exact drop in sensation, only to have it return exponentially stronger 2 months later.
It's just a waiting game.
But this puts the patient in an incredibly precarious psychological position. I mean, if unexpected numbness and strange tingling can be either a harmless biological scab or a minor needle graze that will heal on its own, how is a patient supposed to know if they are experiencing normal healing or a dangerous medical emergency?
Right. Distinguishing between those two things is the single most critical safety skill for anyone considering this treatment. The clinical guidelines draw very stark boundaries around what constitutes a red flag.
Let's go over those. Normal recovery is described as mild tenderness, a feeling of fullness or pressure, maybe a dull ache that peaks in the first few days, even a temporary localized tingling sensation as the inflammation peaks.
Yes. The red flags, on the other hand, are systemic or severe. If you experience a sudden, complete loss of all genital sensation immediately after the numbing cream wears off, and I don't just mean a dullness, I mean an absolute void, that warrants an immediate medical review.
The guidelines also highlight radiating neurological symptoms. If you suddenly develop numbness, tingling, or a shooting pain that travels away from the injection site down into your legs or into your buttocks.
Yeah, that indicates that the inflammation or the hematoma isn't just pressing on a microscopic local nerve. It means it's compressing a major nerve root pathway.
Which sounds incredibly serious.
It is. That type of compression might require urgent medical intervention to relieve the pressure before the ischemia causes any lasting damage.
Right.
Also, if you have severe escalating throbbing pain, especially if it's accompanied by heat or foul-smelling discharge, that is not an artificial scab. That is an active infection.
So recognizing the red flags is crucial after the fact. But our sources are equally aggressive about how you must mitigate your risk before you ever sit in the provider's chair. You really have to interrogate the equipment being used.
Because this is an autologous treatment, meaning it uses your own biological material, the centrifuge is the single most critical variable in the room.
The literature specifically warns against clinics using cheap, generic laboratory test tube spinners to separate the blood. You absolutely must verify the clinic uses a medical grade, FDA-cleared, or CE-marked closed system centrifuge like the Magellan or Region Lab kits.
Because the specific gravity required to perfectly isolate the platelet-rich layer from the red blood cells requires immense precision. If a provider uses substandard equipment, they aren't extracting a therapeutic concentration of platelets.
What do you get instead?
You end up being injected with what the medical texts call platelet-poor plasma.
Which is essentially the worst-case scenario. You are exposing yourself to all the mechanical risks of driving a metal needle into your clitoris, the risk of scratching the myelin sheath, the risk of a suffocating hematoma, but you're delivering a biologically useless fluid.
Exactly. You get all the trauma of the demolition phase with literally none of the growth factors to rebuild the site.
It's an unacceptable risk profile.
It really is. The O-shot is a trademarked, standardized protocol, and that's specifically to mandate certain equipment and training. If a provider gives you evasive answers about their centrifuge technology or exactly what layer of plasma they extract, you have to walk away.
Absolutely. And there is one final massive risk factor that patients have complete control over. It's buried in the post-procedure aftercare instructions, and it involves a common household medication that can single-handedly ruin the entire biological process.
Yes, the NSAID protocol.
This detail is fascinating to me. If you get the O-shot, you are explicitly ordered to avoid NSAID's nonsteroidal anti-inflammatory drugs, like ibuprofen, Advil, aspirin, or Aleve, for 7 days before the procedure and 7 days after.
And if we look at the cellular mechanism of how an NSAID works, the reason for that becomes incredibly obvious. NSAIDs function by blocking a specific enzyme in the body called KOX1.
Okay, but why do platelets care about KOX1?
Because platelets rely entirely on the KOX1 enzyme to aggregate to clump together, and to trigger the release of their alpha granules. If you block that enzyme, the platelet is effectively paralyzed.
Wow. So picture this. You go in for the procedure. The doctor successfully extracts high-quality PRP. They inject it into the tissue, creating the necessary trauma. You go home. You feel a little sore from the needle, so you pop 2 ibuprofen to take the edge off.
And by doing so, you systematically lock the doors on the supply trucks. The ibuprofen shuts down the KOX1 enzyme, the platelets never release their VEGF or PDGF growth factors, and the entire regenerative signaling cascade just halts. You chemically switch off the treatment.
You literally just paid thousands of dollars to get stabbed with a needle, risking hematomas and neuralgia, and then you swallowed a pill that completely neutralized all the healing benefits.
It perfectly illustrates the delicate nature of regenerative medicine. You are completely reliant on your body's innate biological machinery.
Right.
You have to allow that machinery to run its course, to initiate the inflammatory demolition, to build the artificial scab, and to endure the temporary numbness without chemically interfering.
This dive into the mechanics really crystallizes the ultimate decision for anyone weighing this procedure. You are basically balancing the potential for life-changing tissue regeneration against the very real but highly manageable risks of nerve disruption.
We really have to move away from viewing medical intervention as this clean, binary process where a pill instantly fixes a symptom.
Yeah, regenerative medicine is messy.
It is. It involves trauma, inflammation, and temporary regression before you see any progression.
So, to bring it back to our mission today and answer the core question, can the O-shot cause nerve damage, numbness, or loss of sensation? Yes. But the context is everything. Mechanically, a needle grazing a nerve or a small hematoma suffocating a capillary can absolutely cause neuralgia or temporary numbness.
But structurally, permanent damage happens in only a tiny fraction of a percent of cases, and the vast majority of those heal within just a few weeks.
And biologically, a loss of sensation is practically guaranteed in the short term. The PRP triggers that intense inflammatory response, creating an artificial scab that physically dulls the nerve endings while fibroblasts lay down new tissue.
Right, it's a biological construction zone that takes a full 8 to 12 weeks to complete.
But if you ensure your provider uses FDA-cleared centrifuge technology, if you strictly avoid NSAIDs so your platelets can actually do their job, and if you know how to distinguish the normal pressure of an internal scab from the radiating pain of a true medical emergency, the safety profile is actually incredibly strong.
Which leaves us with a pretty profound realization about the human body.
Exactly, because the O-shot doesn't introduce synthetic hormones or foreign chemicals or permanent implants. It literally just extracts a few vials of your own blood, isolates the chemical flares your body already naturally produces, and relocates them to an area that needs repair.
It's merely a localized trigger.
Mm.
The healing material was inside the patient the entire time.
It makes you wonder, if our bodies possess this incredible latent cellular blueprint for profound pleasure, moisture, and regeneration just floating quietly in our veins, how much of what we accept as irreversible, aging like postmenopausal dryness, loss of arousal, stress, incontinence, how much that is actually permanent biological failure?
Mm.
And how much of it is simply a perfectly capable system that has just stalled out, waiting for a highly concentrated, localized reminder to wake up and heal itself?
It really suggests that our capacity for physical connection and repair never really expires. Sometimes the cellular machinery just needs to be forced back online.
Even if forcing it back online requires enduring a microscopic demolition site first. Thanks for taking this deep dive with us today. We'll catch you on the next one.